I was surprised to see in this popular infographic that there was evidently promising evidence that coconut oil could help with obesity. Well, if you pump the stomachs of rats with purified medium-chain fatty acids, one component of coconut oil, they end up eating less food, but you don't know if there's any relevance to humans until you put it to the test. Researchers compared breakfast with the same amount of dairy fat, coconut oil fat, or tallow, beef fat, and no effect on hunger, fullness, satisfaction, or how much they then went on to eat at lunchtime. So where did this whole idea that coconut fat was somehow different come from? Well, 6 years ago, an open-label pilot study was published. They asked 20 men and women to eat 2 tablespoons of coconut oil a day for a month, and the men appeared to lose about an inch off their waist. Now, open label means that the participants knew what they were eating. There wasn't like some placebo control. In fact, there was no control group at all, so you don't know if the effects would have just happened anyway without the coconut oil. There's a well-recognized effect in dietary studies, where just being in a dietary study under observation tends to lead to a reduction in caloric intake, because they're going to weigh you and looking over your shoulder. But there had never been a controlled study of coconut oil and waistlines in men and women until 2015. About 100 men and women were given about a tablespoon of coconut oil a day for 3 months, and lost nearly an inch off their waist after 3 months compared to control. What did the control group get instead? Nothing. There was no placebo, and so they were comparing doing something with doing nothing. And when one does that, there's often a placebo effect, regardless of the true efficacy of the treatment. And they also suggested the coconut oil group may want to take their dose with fruit, and if they did end up eating more fruit, that in and of itself may help, as despite its sugar content, fruit consumption tends to be associated with anti-obesity effects. What we need to see if coconut oil has some special effect is to give people a spoonful of coconut oil versus some other oil and see if there's any difference. And when you do that, 2 tablespoons of coconut oil a day versus 2 tablespoons of soybean oil a day, no significant difference in waistlines. But what did happen was a significant increase in insulin resistance in the coconut oil group, which is what eventually causes type 2 diabetes, despite being told to increase fruits and vegetables, cut down on sugars and animal fat, and despite an exercise program of walking 50 minutes a day, 4 days a week. The only other placebo-controlled study of coconut oil and waistlines was published in 2017, and no significant changes in weight, or waist, or hip measurements, total fat, belly fat, nor butt fat. No benefit to coconut oil for obesity over placebo shown in any study to date. So how can coconut oil proponents get away with saying otherwise? Well, they like to talk about studies like this, showing that Pacific Islanders who ate more traditional coconut-based diets are slimmer than those eating more modern diets with fewer coconut products. But guess what they were eating instead? The modernized dietary pattern was primarily characterized by high intakes of sausage, eggs, and processed foods. In an article entitled "The Treatment of Inoperable Cancer," it was noted that 200 years ago, it was observed that a certain number of malignant growths disappeared after an attack of a type of strep infection, and that was 200 years before 1901, when this was published. A disproportionate number of cases of spontaneous tumor regressions have followed various infections. The thought is that an infection may kind of so rile up the immune system, the cancer may get caught in the crossfire, a phenomenon that may have inspired healers dating back to the ancient Egyptians thousands of years ago. But you don't know until you put it to the test. Though it wasn't formally studied until the 1800s, when doctors started intentionally infecting cancer patients. The most famous proponent was William Coley, the so-called father of immunotherapy at what would eventually become Memorial Sloan Kettering. He was convinced that having a severe infection could cause cancer to regress. So with a great deal of courage, he started injecting cancer patients. The problem, of course, is that causing infections is quite dangerous, and 2 of his patients died. However, their tumors did shrink. If only there was a way we could boost the immune system without killing people. Well, that's the theory behind therapeutic cancer vaccines, one of which has been in practice for decades, squirting a weakened bovine tuberculosis bacteria into the bladders of patients with bladder cancer to make the immune system attack, boosting long-term survival up to 36%. OK, but is there something we can eat that can boost immune function? In my videos on countering stress-induced immune suppression and preventing common childhood infections, I reviewed evidence about a type of fiber in bakers, brewers, and nutritional yeast called beta-glucans, which are considered immunomodulatory compounds, suggested to enhance the defense against infections and potentially cancer. Beta-glucans themselves do not appear to have a direct cytotoxic effect in terms of killing cancer cells, but may boost anti-tumor immunity by activating our immune cells. For example, if you take freshly excised tumors of breast cancer patients and let loose natural killer cells upon them, they can kill off a small percentage of the tumor cells, but first prime them in vitro with some yeast beta-glucans, and they become 5 times more effective at killing cancer cells. What if you just eat it, though? When 23 women with metastatic breast cancer were given just 1/16 of a teaspoon of nutritional yeast worth of beta-glucans, they experienced a 50% increase in the number of monocyte white blood cells in their bloodstream, which are part of our natural defenses, as well as a significant increase in their activation. But it was just a 2-week study. The clinical significance of this finding is unclear. What we want to know is if they actually live longer. The only English-language randomized double-blind placebo-controlled trial of breast cancer patients in beta-glucan was more of a wound-healing study, where they found that the women taking beta-glucan healed so much faster after surgery that the tubes could be removed from their chests and armpits, in some cases days earlier. This was the first clinical study to demonstrate improved wound healing using oral beta-glucans. The other 2, showing benefits for pediatric burns and leg ulcers, were performed using topical beta-glucan preparations, putting it on the skin directly, something that did not appear to reverse precancerous skin lesions better than placebo. But that's because the placebo cream worked so well, too. Both groups showed a significant reduction. They speculated that since each patient acted as their own control, putting the beta-glucan cream on one arm and the placebo cream on the other, that the application of beta-glucans on one arm may have been absorbed into the system and helped on the other arm, given that symptomatic effects have been noted following topical administration. But what effect might oral beta-glucans have on the progression of internal cancers? Yeah, oral yeast beta-glucans can cause dramatic tumor shrinkage in mice, but there appears to be only one human study published in English. 20 patients with advanced cancer on chemo were given a beta-glucan supplement in an open-label, uncontrolled trial. 60% of the patients supposedly reported a sense of well-being while taking the beta-glucan and asked to remain on the treatment after the completion of the study. But that just sounds like classic placebo effect. Same thing with reporting being less tired. But this is interesting. One patient with lymphoma and enlarged lymph nodes in the neck, who delayed his standard chemotherapy for 4 weeks during the study, noted a marked reduction in the size of the nodes while taking the supplement alone. So this, one kind of anecdotal case is interesting, especially since there are no side effects, but not exactly revolutionary. In Japan, there have been more than 20 randomized controlled trials on the use of beta-glucans as an adjunct cancer treatment, which evidently show an enhancement of chemo or radiation therapy, resulting in a positive effect on survival and quality of life. For example, there was evidently a study on taking a yeast beta-glucan supplement to help cancer relapse after surgery. There were no relapses in the treated group, compared to about 1 in 5 in the control group. Even more intriguing, yeast beta-glucans for inoperable cancer patients, end-stage cancer, since only about 1 in 20 patients made it 3 months, and by 6 months, they were all dead. Whereas in the treated group, most survived for more than 3 months. Not 1 in 20, but most, and 43% were still alive after 6 months. Now, evidently, it's not clear how patients were divvied up into treatment versus control groups. If they weren't randomly assigned, they may have inadvertently cherry-picked healthier patients for the treatment group, which could explain the results. Now, I've looked for this study everywhere, so I could get it translated, but even the National Library of Medicine couldn't find it. If anyone out there can, though, I'll do a follow-up video. But the amount of beta-glucan they used is what you'd find in a single pinch of nutritional yeast, which would cost less than a penny, and the only side effect would be tastier popcorn. So why not give it a try? I've explored the role calcium supplements may play in reducing lead exposure during pregnancy and breastfeeding, but this is assuming that the supplements aren't themselves contaminated. It all started with an extraordinary case report published in 1977 entitled Lead-Contaminated Health Food. A doctor prescribed a dietary supplement for a young woman with painful periods. Not just any woman, though. TV and film actress Allison Hayes, famous for such roles as Attaca, the 50-foot woman. And not just any physician, but physician to the stars, Dr. Henry Beeler, who told his patients to forget about toxic drugs. Food is your best medicine, which in this case was a calcium supplement made from horse bone. She took it every day, but got weaker and sicker. And by 1967, her acting career was over when she was unable to walk without a cane. She saw doctor after doctor after doctor to no avail. She decided she could give up, commit suicide, or figure it out herself. So she had some friends drive her to a medical library. By then she couldn't even walk and had to be carried in. She sat on the floor day after day, and finally came across a book on industrial toxicology that described what she soon realized was a classic case of lead poisoning. She paid to have the calcium supplement tested, and indeed it was full of lead. At first, she was relieved, but then the anger set in. Doctor after doctor had basically dismissed her as hysterical. She had to depend on herself to end up educating them. The silver lining was that the FDA, in a letter, actually credited her for being a key stimulus for their plans to look into regulating heavy metals in foods and supplements. Unfortunately, the letter arrived after she had already died, from leukemia, which may have been triggered by the lead poisoning, or the 300 X-ray exams she got from those 22 baffled physicians. You'd think the supplement industry would clean up its own act, but perhaps it's unrealistic to expect the health, food, and wellness industry to dampen their evangelistic promotion of these products on their own. Where did the lead come from? Well, lead gets stored in your bones, and so when you eat supplements made out of bones, you can get exposed. So was that one calcium supplement just a tip of an iceberg? At first we thought it was just from the bone supplements and dolomite, a mineral that can be lead-contaminated, but then calcium carbonate, oyster shell calcium, chelated calcium, was found to have comparable lead levels to animal bone. And so this inspired a comprehensive survey of the lead content of 70 different brands of calcium supplements, and lead levels varied by almost 300-fold, some of which 2, 3, or even 4 times the tolerable daily intake of lead for children, especially the most common natural source calcium like oyster shell, with more than half exceeding the benchmark for children. A follow-up study confirmed that most calcium supplements from natural sources exceeded at least some of the most stringent lead standards, but the levels only got up to about 8 micrograms, whereas some of the synthetic sources were up to 3 times that. A small human study of calcium citrate was performed, in which bone biopsies were taken before and after about 5 years of supplementation. No change in the control group, as expected, and only a statistically insignificant increase in the calcium citrate group, though one can't assume that a given brand is uniformly safe, because some of their products may have high and others low lead levels. So name brands or recognized pharmaceutical companies that should know better are no guarantee. But the good news is that after decades of concern, lead levels in calcium supplements have come down, so much so that lead level changes in your blood taking the average lead-contaminated calcium supplement would be minimal at this point. So these findings on supplement lead contamination should be a cause for celebration, not alarm, or at least according to a calcium supplement manufacturer consultant. Selling cancer screening can be easy, starts an editorial in the Journal of the National Cancer Institute. Induce fear by exaggerating risk, then offer hope by exaggerating the benefit of screening, and don't mention harms caused by the screening. This ploy is especially easy with cancer. No diagnosis is more dreaded. And we all know the mantra, early detection is the best protection. Doubt it, and someone may suggest you need your head examined. And they are not exaggerating. Screening can lead to important benefits, but it can also lead to important harms. And so that's the big challenge, conveying the counterintuitive idea that screening doesn't always help and can even be harmful. Yet surveys have shown that most people believe that cancer screening is almost always a good idea, and few believe harm is even possible. In patient education materials, passing references to potential harms may deceptively be buried under a euphoria of benefits. The cancer screening test that has been most carefully studied is mammograms. In the past 50 years, more than 600,000 women have participated in 10 randomized trials. Given this extraordinary research effort, it's ironic that mammograms continue to be one of the most contentious issues within the medical community. There are few things in medicine that invoke more passion than mammograms, with both sides, ironically, accusing the media of being in the opposite camp. But this contentiousness is in itself instructive. It should tell us something. For context, a single study involving fewer than 150 men who were followed for less than 2 years was sufficient to convince physicians of the value of treating severe high blood pressure, because the benefits were just so obvious. Whereas after 10 trials, 600,000 women, the fact that we're still debating the merits of mammograms 50 years later suggests that it's a close call between the benefits and harms. But that's assuming people are weighing the pros and cons objectively. It may be worse than that, given the multi-billion-dollar industries involved, from the mammogram machine manufacturers to the radiologists that read them. Several organizations publish contradictory cancer screening recommendations. Some say mammograms starting at age 40, others say 50. Some say every year, some say every other year, and some say women shouldn't get them routinely at all. There's increasing concern that these disagreements may be arising from both financial and emotional conflicts of interest. People can get so invested in their position that they've staked out that it kind of clouds their judgment. Reasonable experts agree that the body of evidence suggests that there is some benefit to mammography. Although the benefits have almost certainly been exaggerated, this does not mean that mammograms don't save lives or that women shouldn't get them. The question is, do the benefits outweigh the risks? That's the decision each woman has to make for themselves, but they can't do that without knowing all the facts. Women are so bombarded with information about mammograms, you'd think women would be fairly knowledgeable about it, yet nothing is farther from the truth. 9 out of 10 women surveyed vastly overestimated the benefits or had no idea. It's not the women's fault, though. They're obviously being misinformed by the system. Most American women didn't even appear to understand the basic concept of screening, thinking mammograms somehow help prevent you from getting breast cancer in the first place. This raises doubts about how well women are being informed. It sounds like women are just being told what they should do, but without being given the facts necessary to make informed decisions. As a result of this paternalism and pink ribbon culture, almost all women have a false impression of the benefit of mammography screening. Most surprisingly, those who frequently consulted their physicians and health pamphlets were slightly worse informed, so they were like anti-educated by their doctors. And the problem is that these kinds of inaccurate and exaggerated perceptions prevent women from making an informed choice. Misleading women, whether intentionally or unintentionally, is a serious issue. All of those in the business of informing women about screening should recall that medical systems are for patients, not the other way around. We should not just blindly be selling screening. We should be giving people the numbers they need to decide for themselves. That's why I created this video series. The question of whether screening mammography does more harm than good has the potential to shake up the state of our medical knowledge, alter our views of ethical medical practice. The stakes are high in this discourse because women's lives hang in the balance. For nearly a century, public health organizations, professional associations, patient advocacy groups, academics, and clinicians largely viewed cancer screening as a simple, safe way to save lives. But these days, even though we're all looking at the same body of evidence, differing interpretations about the benefits and harms of mammograms has led to conflicting recommendations that range from intensive annual screening starting at age 40 to no routine screening at all ever. Currently, the four main groups in the U.S. charged with making mammogram recommendations each set contradictory guidelines. So what's a woman to do? Well, the guidelines are based on systematic reviews of the evidence. In the last 15 years, 50 such reviews have been published, but they don't all reach the same conclusions. The question is why. It turns out the conclusions of systematic reviews may have been influenced by competing conflicts of interest of the authors. Only in healthcare does the same group that provides a service also tell us how valuable that service is and how much of it we need. We must sadly acknowledge that just as in any other profession or industry, self-interest is unavoidably at work. In an analysis of more than 100 papers, the imbalance in those that tended to emphasize the major benefits of mammography over its major harms was related to the author's affiliation. It may be no coincidence that all the expert panels that have come out against routine mammograms excluded radiologists, figuring those who depend on mammograms for their paycheck might be more likely to recommend them. To which mammogram proponents respond, if you don't have a conflict of interest, you're probably not doing it right, accusing the breast cancer screening panels of injecting their own biases. In this debate, there are armies of the faithful and only a disappointing scattering of moderators and peacemakers. Some have even suggested that we shouldn't even be talking about this in public. But such paternalism assumes that women cannot decide for themselves whether the available evidence supports or refutes the case for mammography. Discouraging a discussion with women about the evidence for and against could be considered more harmful for women's health, not less, if doctors truly believe that patients should be active partners in making decisions about their own bodies. Yeah, if you read the actual studies, you can see if the investigators declare any conflicts of interest. But if you just hear about the studies secondhand, you may have no idea. Until the developers of screening guidelines emphasize evidence over commercial or financial interests, we all have to take personal responsibility to become informed consumers. It'd be nice to be able to just trust, like, cancer charities, but it's virtually impossible for such organizations to remain strictly evidence-based when they must rely on keeping donors happy for their very existence. To his credit, the chief medical officer of the American Cancer Society said that we need to be true to the science. But note, this was him talking about prostate cancer screening. See, the American Cancer Society just straight up tells women to get mammograms, but for men, it leaves them to decide for themselves. They're open about the prostate cancer screening harms, but very little transparent information about the harms of mammograms is provided. So there's this double standard. Women are encouraged to just do it, while men are advised to weigh the pros and cons, although the fundamental issues to consider are actually very similar between the two tests. The dissimilarity in how organizations like the American Cancer Society view the patient's role in decision-making couldn't be clearer. Do they believe that men can handle uncertainties regarding screening tests, but that women might just get all confused? Men get to make informed decisions about their bodies, but women are merely summoned. The bottom line is that there is more than one right answer to the question, should I be screened for breast cancer? My goal I have for this video series is to enable you to make the decision that is right for you or your loved ones. One survey suggested that if women were fully informed at how small the benefit actually was, 70% wouldn't do it. But you may be in that 30% and have a right to decide for yourself. In 1943, a famous paper was published in which a child psychiatrist at Hopkins described a series of children with so-called fascinating peculiarities. He thought these characteristics formed a unique syndrome he called autism, which seemed rare at the time, but who knew how many were out there undiagnosed? What causes it? Autism is currently considered a multifactorial disorder resulting from both genetic and non-genetic risk factors. Yes, it can run in families, but genetic factors may account for only 10 to 20% of autism cases. This is based in part on the fact that you can have identical twins with identical DNA, the same genes, and one identical twin may have autism and the other not. So while genetic susceptibility may be a key contributor to these autism spectrum disorders, it may just load the gun, so to speak, with prenatal, perinatal, and postnatal environmental exposures, some kind of exposures during, around, or after pregnancy being the events that pull the trigger and may actually give rise to the disease. This is good news. The larger role these non-genetic factors play in causing autism, the more modifiable the risk factors may be, potentially opening up avenues for the primary prevention of autism in the first place. Since autism as a medical condition was first described, the prevalence of autism has apparently exploded from like 1 in 5,000 individuals to 1 in 68 now, more than 1% of the population. That would be like a 7,000% increase. And indeed, you'll see graphs like this, showing an exponential increase in the prevalence of autism from like no diagnosed cases in the early 1900s, to the prevalence shooting through the roof in the 80s and 90s. And so that immediately gets you thinking, what happened around that time that could account for the explosion? But wait a second. Of course there were no diagnosed cases in the early 1900s. It didn't even have a name until 1943. As Kanner said in the original paper, there's probably more cases out there, but they just hadn't been looking. So this isn't a graph of the prevalence of autism, it's a graph of the prevalence of autism diagnoses, and that depends on what diagnostic criteria you're using and whether you're out there looking for it or not. Put another way, historical prevalence estimates for autism and its rarity might well have been underestimates of the true prevalence back then. We may have just been missing lots of cases. The increased recognition among doctors and society at large, the broadening of the diagnostic concept over time, and different studies using different criteria may account for much of the apparent increase in prevalence, although this can't be quantified. So before we start speculating about the reason for the explosive increase, maybe we should first make sure the explosion is real. The bottom line is that while we may never really know what the prevalence was a half-century ago, we do have decent data over the last few decades that really does point to a considerable increase in the true prevalence. So yeah, maybe there wasn't actually a 22-fold increase in autism in the 80s and 90s. Maybe there was actually only an 8-fold increase. So yeah, we may quibble whether the increase was 800% or closer to 2,000%, but the bottom line seems to be autism rates are really increasing. And so the question legitimately then turns to Why? The prevalence of autism has increased dramatically in the U.S. We're not exactly sure how prevalent it used to be, but these days, about 1 in 68 kids born in the United States will have it. Despite a massive influx of research funding, we still don't know what's the cause. This sharp increase in prevalence remains unresolved. Yes, changes in awareness and diagnosis can account for some of the increase, but it also might be something we're exposed to in the environment. For example, all the new chemicals we're now exposed to. Out of 80,000 agents the chemical industries now put out, we have evidence that at least 1,000 may have neurotoxic properties, yet only a small fraction have been studied in humans during critical windows of development. The current chemical risk assessment approach is typically based on the toxicity caused by a single chemical, without acknowledging the effects of different chemical mixtures. There are hundreds of chemicals currently allowed in food that may have potential harmful effects on the developing brain. Each individual chemical may or may not have a harmful effect on its own, but we know next to nothing about their cumulative biological effects on the brain. If we really want to protect children's brains from chemicals, we first need to recognize and deal with a massive dearth of basic hazard and exposure information about any risks posed by environmental chemicals. A lot of the data we do have is from preclinical studies, meaning like test tubes and lab animals. Well, yeah, it's not like you can expose people on purpose. That's where epidemiological research can step in, studying exposures within populations. That's how we found out about other well-known hazards like benzene and asbestos. You can't ethically force people to smoke for a study, but you can note how many people exposed to cigarette smoke day in, day out get lung cancer compared to non-smokers. Industries spewing poison like to patronize the public that we shouldn't worry our pretty little heads, but what does the science show? What does the epidemiological evidence have to say about exposures to environmental chemicals and autism? For example, there's a bunch of studies on the effects of smoking during pregnancy on autism rates. I've talked about these so-called forest plots before, where values greater than 1 suggest at least a tendency towards an increased risk, whereas the values less than 1 suggest more of a protective association. And should the whiskers here cross the line, then that means that particular finding did not reach statistical significance. This allows you with a quick glance to interpret a huge amount of data from multiple studies. So regarding this figure here, does it look like smoking during pregnancy has any effect on autism rates? No. About half skewed to one side, half to the other, and hardly any of the results reached statistical significance, meaning they may have just been largely chance findings. Same thing with thimerosal exposure, the mercury-containing preservative used in vaccines. Yeah, one study found significantly increased risk of autism, but 3 other studies found that those with more vaccine mercury exposure had lower the risk of autism. But mostly they just showed no relationship either way. Not that it matters much at this point, since thimerosal has been removed from most vaccines. But check out the air pollution data. This is exposure to car exhaust and diesel fumes during pregnancy and infancy. See how all the data is skewed to the right, with half the findings reaching statistical significance, meaning a significant correlation between air pollution and autism. But correlation doesn't necessarily mean causation. This could be a true cause-and-effect relationship, or maybe it's just that poor people live in the inner cities next to polluted highways, or the traffic noise is causing stress, or some other confounding factor. The other suspicious link they found was pesticide exposure. Again, just a few-second blink at this chart, and you can see where most of the evidence trends. Lots of environmental toxicants have been implicated in autism: plastics, chemicals, PCBs, solvents, toxic waste sites, and heavy metals. But the strongest evidence has been found for air pollutants and pesticides. Yeah, clinicians can advise pregnant women and parents to try to avoid exposures to harmful substances in their environment. But instead of just advising patients one by one, a more powerful strategy would be for us clinicians to band together and take a leadership role in advocating for a healthy environment and society-wide actions to help everyone. Various health organizations offer clashing mammogram recommendations that range from annual mammograms starting at age 40 to eliminating routine mammograms altogether. It's hard to know who to trust, given all the various conflicts of interest, but a good place to start is the USPSTF, the U.S. Preventive Services Task Force, whose 2009 recommendations ignited a firestorm of controversy by recommending pushing back routine mammograms from age 40 to 50 and doing them every other year instead of annually. This evoked a swift and decidedly passionate condemnation from members of the public, the media, and medicine. Most people have never even heard of the USPSTF, but it's considered the leading independent panel of non-governmental experts when it comes to prevention, considered the gold standard for preventive care, since they have a reputation of sticking more with the science, for example, recommending against teaching women to do breast self-exams. Why? Because it doesn't appear to work. It was put to the test, hundreds of thousands of women randomized to do self-exams or not, and no benefit. In fact, only harms, doubling the number of women who had to get biopsies taken, but not actually shown to decrease the risk of getting breast cancer or dying from breast cancer. It didn't catch tumors in earlier stages. Now, to be clear, they didn't come out against breast self-examination, but against teaching women how to do them. Reminding them to do them only appears to cause harm with no benefit. If you do discover an abnormality, then definitely tell your doctor. But telling women to get into the practice of looking seems to do more harm than good. Yet most doctors continue to teach women to perform self-exams. But wait, it's not been shown to help, and in fact has been shown to harm. So why do doctors keep doing it? Because that's just what we've been telling women forever. So there's this medical inertia that may trump women's health, even without a multi-billion-dollar industry pushing for the practice to continue, even without big business tipping the scales. Now consider mammograms. Billions of dollars of revenue every year from sticking with the status quo. Maybe the $7.8 billion spent annually on mammograms might be better spent on something else. Of course, one person's cost is another person's income. These billions of extra dollars from the status quo may best explain the organized resistance to the USPSTF panel conclusions. For example, breast radiologists denounced the panel, implying that the panel members were guilty of a callous disregard for the life and well-being of women, all while the American College of Radiology is receiving millions of dollars of donations from mammogram machine manufacturers. Yeah, but in the case of self-exams, it was put to the test, and the science was clear. It's a no-brainer that harms outweigh the benefits when apparently there are no benefits. And the same appears to be the case with starting mammograms at age 40. It was put to the test to specifically address the population-wide efficacy of mammography screening starting at age 40, and it started out looking like it might help, but ultimately failed to show any benefit in terms of lowering one's risk of dying from breast cancer. Instead, they just found harms, so-called overdiagnosis, all the chemo, radiation, and surgery from the detections of what looked like cancer, but may have never caused any problems had they never been picked up. So it may have just resulted in unnecessary mastectomies. Yet when the USPSTF tried to explain that again in their 2016 recommendations, the firestorm was reignited with full-page ads taken out in major papers asking which of our mothers, wives, daughters, and sisters would it be okay to lose. But that misrepresents the science, disrespecting women rather than saving their lives. It's time to douse the flames, clear the smoke, so we can clearly see what the evidence shows. Evidence schmevidence, said Congress, who snuck in some language to interpret any reference to current USPSTF breast cancer screening recommendations to mean those issued before 2009. In other words, it's 2002 recommendations that recommended annual mammograms starting at age 40. Essentially, Congress is requiring health insurers to ignore modern scientific assessments and instead use a 15-year-old guidance. Although many women's health advocates applauded the congressional mandate, it could be viewed as undermining women's rights to make informed decisions based on the best scientific evidence. The same thing happened 20 years ago, when a National Cancer Institute consensus panel arrived at the same conclusion. But the Senate voted unanimously to ignore them. The #1 killer of women is heart disease. Why not focus our billions on more effective interventions? Since healthcare dollars are limited, maybe we could be doing more for women's health. But hey, it could have been worse. The original bill would have denied funding for any future USBSTF mammography recommendations, period. And some members of Congress even proposed to alter the task force composition to include stakeholders from the mammogram machine manufacturers so they can play a more direct role in influencing policy. What was the impact of the 2009 shift in recommendations to delay routine screening until age 50? Ironically, mammography rates of women in their 40s may have actually gone up. The thought is that all the media attention may have just reminded women about it, underscoring the need to better translate evidence into practice. The new recommendations bring the U.S. closer to European standards, mammograms every few years, starting at age 50. In 2015, the American Cancer Society split the difference and recommended starting at 45 annually, then switching to every other year at 55, suggesting this would decrease the lifetime risk of dying from breast cancer from 2.7% down to under 2%. Based in part on a systematic review performed by the Cochrane Collaboration, a highly respected bastion of evidence-based medicine. The authors of the Cochrane Review, however, wrote in to say they used the wrong number, and that if you look at the studies they considered were adequately randomized, there did not appear to be any significant mortality benefit from mammograms at all, and that the data certainly do not support the popular idea that breast cancer screening saves lives, accusing the American Cancer Society of being more of a political organization with financial ties to the multi-billion-dollar mammogram industry. Here's the Cochrane Review they're talking about, which concluded that the studies which provided the most reliable information evidently show that screening did not reduce breast cancer mortality. If that's true, then that changes everything. They conclude that the time has therefore come to reassess whether routine mammograms should be recommended for women of any age, which is what the Swiss Medical Board did. They were struck by how non-obvious it was that the benefits of mammography screening outweighed the harms. It's easy to promote mammography screening when the majority of women believe that it prevents or reduces the risk of getting breast cancer and saves many lives through early detection of aggressive tumors. If those beliefs were valid, they'd be all for it. Unfortunately, they concluded they are not, and so believe that women need to be told so. From an ethical perspective, a public health program that does not clearly produce more benefits than harms is hard to justify. Their report, not surprisingly, caused an uproar. Critics argued that the report unsettled women. But we wonder how to avoid unsettling women given the available evidence. If you ask women what they perceive to be the benefits of regular mammogram screening, they think it cuts the risk of dying from breast cancer in half. That's the orange box, saving the lives of about 1 in 12 women, but in reality, the numbers appear to look like this. First of all, the risk of dying from breast cancer regardless is smaller than most women think, and the reduction in risk, the differences in size of the orange boxes, is much smaller. Maybe only 1 in 1,000 women benefits. But hey, doesn't saving the life of even 1 in 1,000 women make it all worth it? Imagine if you were in that 1 in 1,000 families whose mom was saved. But that may not be true. 1 in 1,000 women screened may not die from breast cancer, but there's no evidence to suggest that overall mortality was affected, which would mean no lives are actually saved. There's been 10 randomized trials of mammogram screening, and not one has ever showed an overall mortality benefit. Wait, how does that make sense? If mammograms prevent 1 in 1,000 women from dying from breast cancer, then the only way no lives are saved is if mammograms ended up somehow leading to the deaths of 1 in 1,000 healthy women. That's preposterous, right? Let me introduce the concept of overdiagnosis. The fact that some of the tiny tumors picked up on mammograms may have never progressed, or even disappeared on their own, And so had they not been picked up, the woman would have been none the wiser and would have never been affected by it or even known they had it. But once you pick up a cancer on a mammogram, you have to treat it since you don't know what it's going to do. But in some cases, the overdiagnosed cases where it would never hurt you, you're treating the breast cancer unnecessarily. How common is that, though? For every life saved by mammography, as many as 2 to 10 women are overdiagnosed, meaning turned into breast cancer patients unnecessarily, along with all the attendant harms of chemo, radiation, or surgery without the benefits. Harms can include death. Imagine being in the family whose mom was killed. The concern is that unnecessary radiation treatments may kill as many as are saved, hence the no evidence of net mortality benefit. Radiation treatments to the chest increase the risk of dying from heart disease and lung cancer. Now, those may be acceptable risks if you actually have breast cancer that would otherwise kill you. Treatments that are beneficial for real patients can be lethal for those who never should have been treated in the first place. Even if mammograms don't save your life, might they save your breast? I mean, if you catch a tumor early, maybe you can avoid a mastectomy. The opposite may actually be true. The Cochrane researchers explained that that's why they published their report. They thought it was important for women to know that screening may increase their risk of losing a breast. Basically, mammograms have been promoted to the public with 3 simple promises that all appear to be wrong. Screening does not seem to make the women live longer, instead may unnecessarily increase mastectomies, and cancers are not caught early. It may take decades for a tumor to grow large enough to be picked up on a mammogram, and even when they are, they may not grow any further. That's the concern we're catching too many. There's so much overdiagnosis that if a woman really doesn't want to become a breast cancer patient, maybe they should avoid mammogram screening altogether. But if you have breast cancer, don't you want to know? The small probability that a woman may avoid breast cancer death must be weighed against the more likely scenario that she may have a false positive or false negative result, or, most critically, a diagnosis and treatment of cancer that would otherwise not have threatened her health or even come to her attention. What are the effects of avocado on metabolic syndrome, which is a clustering of risk factors: high blood sugars, high blood triglycerides, high blood pressure, and obesity. That sets you up for diabetes and heart disease. Avocado consumption is associated with not only better diet quality and nutrient intake, but lower metabolic syndrome risk. Avocado eaters only had half the odds of metabolic syndrome. The study was funded by the Avocado Board, though, so it's especially important to dig into how they designed it. The data came from a snapshot-in-time cross-sectional survey of about 17,500 people, who were asked if they had eaten any avocado in the last 24 hours on 2 separate occasions. 2% said yes, and so the health stats from the few hundred folks who reported they had eaten avocado recently were compared to the health stats of the 17,000 individuals who said they had not. And the proportion of people with metabolic syndrome among the avocado group was only half that of the non-avocado group. And they were slimmer, too, significantly trimmer waist and lower body weight, despite no significant difference in caloric intake. The authors treat this as some kind of mystery, but it was just how many calories they ate on the day of the surveys, not over time. Though you could see how people could lose weight. Avocados, like all fruits, are mostly water, along with fiber, which have no calories at all. So a smear of cream cheese on a bagel would add more than twice as many calories as the same smear of avocado. But that brings up an important point. Maybe those who eat avocados just tend to have healthier diets in general. I mean, if you're spreading avocado on your toast, maybe you're spreading less butter or margarine. And indeed, avocado eaters also reported eating more fruits and vegetables in general, and less added sugar. No wonder they were healthier. It's right there in the title. Avocado consumption is associated with better diet quality. So this is in effect saying that those who eat healthier are slimmer and have a lower risk of disease. Well, duh. And this could be in part because they were eating avocados, have nothing to do with the avocados, or even in spite of the avocados. You don't know until you put it to the test. What is the effect of avocados on body weight? It's evidently evident from some study that an avocado extract caused a reduction in body weight. But the study was on the body weight of rats, and it was an avocado leaf extract. Who eats avocado leaves? Well, evidently in Nigeria, an herbal remedy for high blood pressure is avocado leaf tea. Does it actually work? Researchers tried it out on some hypertensive patients, and it seems avocado leaves have a toxic effect on the liver that could cause liver damage. So yeah, I guess technically it can be used in the treatment of hypertension, but only if you don't care about the pesky hepatotoxicity. No thanks. Are there no human studies on avocado fruit and body weight? Well, evidently there was a study 50 years ago, back in 1960, on avocados and cholesterol, in which the subjects did not gain weight when avocados were added to their diet. I did find a reference to the study in the California Avocado Society yearbook, lamenting how difficult it is to impress the housewife as to all the unnamed benefits of avocados. Now, it's true that body weights didn't change much after avocado feeding, but they didn't just add avocados to their diet, they substituted avocado for some of the animal fat they were eating. So they swapped out lard for avocado. No wonder there was no weight gain. Now, in one subject, they did just add the avocado, started out at 154 pounds, and after 3 weeks of added avocado, no weight gain. OK, so maybe avocado is so satiating, so satisfying, that when you add it to your diet, you just naturally end up eating less of other stuff. But you don't really know until you put it to the test. A randomized controlled study to evaluate the effect of Hass avocado intake on satiety and subsequent caloric intake. Adding half an avocado to a lunch meal did improve satisfaction and reduce hunger. But they just added an extra 112 calories of food. Of course they felt less hungry. The question is, did they feel so much less hungry that during supper they ate 112 calories less to compensate? And the answer is no. In fact, they didn't eat significantly less at all. What about over time? This study added an entire avocado to people's daily diets for 6 weeks and found no significant weight gain, so they triumphantly claimed to dispel the myth that avocados are fattening. But this was like the lard study. Yeah, they added an avocado, but they removed the same amount of fat in the form of margarine, mayonnaise, and oil. Now, this is a healthy swap. Removing junk and adding nutrition, adding fiber. But if the calories in and out are the same, then no wonder no difference in body weight. In fact, one could have just as well concluded that avocados are as fattening as margarine, mayonnaise, and oil if you're eating the same amount of fat. Maybe the housewife was unimpressed because she just knew a little something about proper study design. In response to the Swiss Medical Board's recommendations against women of any age getting routine mammograms, critics suggested that instead of phasing out screening programs completely, we should leave it up to each woman individually to make her own judgment once she's fully informed about the pros and cons. On the basis of the same information, some women will choose screening and others will not. I agree. That's why I'm doing this video series, to lay out the benefits and the harms. When it comes to medical treatments, I think most patients understand there are risks and benefits. Drugs can have side effects, surgeries can have complications. So you can make your decision based on whether you think the benefits outweigh the risks. But patients have been taught to think differently about screening. What's the harm? Who wouldn't want to know if you have cancer? It's a no-brainer. But in reality, the truth is more nuanced. There are benefits and harms to consider in screening, just as there are in treatment. In the case of mammograms, the most frequent harm is a false positive result, where they think they see something in the scan, but after further testing, more X-rays, ultrasound, or a biopsy, it turns out to be nothing. Phew! As you can imagine, this can cause a roller coaster of emotions. Experiencing a false positive result can be an agonizing experience, sometimes profoundly affecting a woman's life. Some women can get depressed, anxious, lose sleep over it, even months later. Even after getting the all clear, breast cancer worries can persist, even a year or more later. And beyond psychological effects, if you have to go in for a biopsy, they obviously use local anesthesia during the procedure, but the pain afterwards can sometimes persist for days or weeks. These adverse consequences would be less concerning if false positive mammograms were uncommon events. Unfortunately, most women will get at least one false positive mammogram within 10 years of annual screening, though the chances that a single mammogram will produce a false positive is only about 10 to 14%. But that's way more than over in Europe, for example, where it's only like 1 in 20 or 1 in 50. That's thought to be because American radiologists are so afraid of being sued for malpractice that the bar they use is much lower. And that's fine for a lot of women. Even if 10,000 women have to go through false positives, many feel it would be worth it to save a life. Even many women who had themselves experienced a false positive result firsthand, so they know what it's like. Most women don't even want to take false positives into account when deciding about screening, but some women do. For some, going through a false alarm is no big deal, but for others it can be really scary. Some women interviewed going through the process were described as being in a state of emotional chaos, facing a possible cancer diagnosis. Waiting for the results was particularly hard for some women. It was constantly on their minds. But after it was over, many women were able to just brush it off, whereas others had persistent anxiety even though they were given the all clear. Studies have noted increased anxiety on average even months later after being called back for a suspicious mammogram that turned out to be nothing, or even years later. A study of hundreds of women who experienced a false positive, and some appear to be suffering the consequences even years later. They were followed up for 3 years, and the experience still seemed to haunt them. So maybe we shouldn't just dismiss these false alarms. Regardless, women should be informed of the possibility and reassured that most women who are recalled back for further testing of a suspicious mammogram finding do not end up having cancer after all, so as to put their mind at ease a bit as they go through the process and wait for the final results. False positive results have been described as the most frequent harm associated with mammogram screening, but actually, it may be pain. There's a wide variation both in the reported frequency of pain and in degree of pain felt by women during mammograms. But there may be little doubt that the majority of women feel some degree of pain during the procedure. Why? Isn't that just some type of X-ray? For those unfamiliar, the breast is sandwiched between two plates and kind of pancaked down. Instructions are typically like, slowly apply compression until the breast feels taut, with a force not exceeding 20 kilograms. That's 44 pounds. It's like the weight of a cinder block. No wonder some women experience pain. Studies have attempted to quantify it are all over the place, with the incidence of pain ranging anywhere from 1% to 93%, depending on how they defined it. The discomfort is enough to keep a proportion of women from not coming back. The typical line you hear is that although the compression can be uncomfortable and even painful for some women, it only lasts a few seconds, a sentiment to which one woman replied, "You tell the doctor to come on over, he's got stuff that can be mashed too, you know." Mammogram compression can cause bruising and has led to the rupture of breast implants, cysts, and blood vessels. Women with dense breasts are often advised to take painkillers or tranquilizers to endure the procedure more comfortably. Yet, pain is there for a reason. It's trying to warn us about potential tissue damage. There's at least a theoretical concern that tissue inflammation could wake up dormant tumors, but that's sheer speculation at this point. Still, we could try to make them less painful. The reason they do it is to reduce breast thickness, purportedly decreasing the radiation dose and improving image quality. But when it was put to the test and actually measured, one study found the radiation dose increased at higher compression forces. Another study found that about a quarter of women did not experience a difference in the thickness of their breast when compression was eased back a bit, implying that more compression was applied than necessary. Once minimum thickness is achieved, then further compression only results in more pain, with no benefit to image quality. The bottom line is that pain in mammography is an issue to be taken seriously. Recognizing this in the tone and content of patient information and advising on ways to deal with it would show greater respect for patients than just blanket reassurances. The reason women aren't more up in arms may be that the majority of women feel compelled by fear or duty to comply, but this just helps the medical establishment push the pain issue to the margins. Recurring canker sores is the single most common inflammatory and ulcerative condition of the mouth, affecting as many as 1 in 5 people. Ouch. Sometimes it can be a sign of celiac disease, a relatively rare autoimmune condition triggered by the wheat protein gluten. But what about those without celiac disease? Well, 37 years ago, there was a report of a small group of recurrent canker sore patients that got better after removing gluten from their diet, despite the fact that they didn't have any signs of celiac disease. Now, without a control group, you don't know if they wouldn't just gotten better on their own, but it was interesting enough to spark further study. Given that small series of patients, they decided to try out a gluten-free diet on 20 folks with recurring canker sores, again explicitly excluding those known to have celiac disease. And 5 of the 20 seemed to get better. And critically, then they got worse when they were challenged with gluten. So even though there was no control group, in the few that got better, the ulcers came back when gluten was added back to their diet. Now, this was not just some random group of canker sore sufferers. The reason they had gotten intestinal biopsies to rule out celiac was because they had some other abnormality. So you can't extrapolate from this study saying 1 in 5 sufferers may benefit from cutting out gluten, though at least it appears in some people to help. Though it would have been better if there was some blinded challenge. I mean, if you cut out gluten or any food and just coincidentally happen to feel better, you might convince yourself that gluten was the culprit. And so then when the researcher gives you a piece of bread, maybe just the stress at the thought of your ulcers coming back may actually help trigger the ulcers from coming back. And that's why, ideally, you do blinded gluten challenges to see if gluten really is to blame. For example, if you take people who don't have celiac or wheat allergy, but nevertheless claim to be sensitive to gluten, you can test to see if they're fooling themselves by randomly assigning them to take a capsule with gluten inside, or just a placebo made out of rice starch. So they're on a gluten-free diet, and then you give them this pill, which in the case of the gluten one is equivalent to like 2 pieces of bread, and you see if they get worse. And then just the thought of taking something that might be gluten, their symptoms shot up. And this was them just taking a placebo rice starch pill. But the reason we know this non-celiac gluten sensitivity exists is that the actual gluten pill made them feel even worse. And that's specifically what happened in the case of canker sores. Those who felt they were gluten sensitive did actually get more canker sores exposed to real as opposed to fake gluten. Where did they even get the idea in the original study to try cutting out gluten? Well, back in the 60s, it was reported that the blood of patients with bad canker sores reacted to certain food proteins like gluten, but had an even stronger reaction to the milk protein casein. This has since been more formally tested. 50 patients with recurring canker sores were compared to 50 healthy people for their levels of anti-gluten antibodies. Gliadin is a type of gluten protein, and anti-cow's milk protein antibodies. And the canker sore sufferers were no more likely to react to the gluten, but the levels of anti-milk proteins were significantly higher. In fact, the majority reacted to the cow's milk. These results indicate a strong association between high levels of anti-milk proteins in the blood with recurring canker sores. But what we care about is, do people actually get better or not when they cut out the milk? Well, upon hearing their results, 3 of the patients spontaneously decided to cut out all dairy products from their diet for a few months to see what happens. And it seemed to help. No reappearance of the sores in the first patient. Same with the second, until they had some cow's milk ice cream. And in the third, the ulcers seemed to come with less frequency, but those were just some observations, not an actual study. You see the same thing with certain food additives. Folks with recurring canker sores may react more to certain food dyes, and so if you try people on a gluten-free diet, or a dairy-free diet, or a diet free of certain food additives, you'll get a few cases of people responding, in this case 6 out of 11. Some better on the gluten-free, others better on the milk-free, others on the additive-free. But the responses were pretty dramatic, seen within a week. So it seems it might be worth giving these exclusion diets a try to see if there's a huge improvement. Can't you just get an allergy test or something? Apparently not. For example, this poor woman, who suffered from recurring canker sores since she was 2 years old, multiple painful lesions in her mouth almost constantly. They asked her about milk, and she said she rarely drank it because it appeared to trigger more almost immediately, so they decided to look into it. They tested her for sensitivities to dairy, both so-called prick and patch allergy tests, and they were both negative. But hey, if she felt worse on dairy, might as well try cutting out all dairy products completely, and for the first time in her life, the ulcers went away and stayed away, unless she actually had some milk product. So even if people test negative, it may be worth a try to cut out all dairy and see what happens. Look, we know cow's milk may play a role in other allergic and autoimmune-type diseases, and there are these reports going back decades suggesting at least there's a subgroup of canker sore patients for which dairy is a causative factor. However, awareness of this association is rare among both patients and healthcare providers. And improvement can happen rapidly. A boy and a girl both suffering for years with frequent multiple ulcerations, then apparently cured within 2 weeks. We don't know how often it works, we just know it does. Sometimes. So as this 2017 paper in the Journal of the American Dental Association suggests, why not give a cow's milk protein elimination trial a try, particularly before the use of medications with potential side effects? Over the last few decades, our radiation exposure has nearly doubled, thanks almost exclusively to medical sources, such as CT scans. We've known that higher-dose radiation, like CT scans and angiograms, can cause breaks in our DNA, but now we know that mammograms can too. You can find X-ray-induced DNA damage in white blood cells drawn from women right after her mammogram. That's amazing. They can find evidence of DNA break. I mean, how much blood is there in the breast in the first place? And then you squeeze it out during the procedure, and then it mixes with the unexposed blood from the rest of the body, and you can still pick up the DNA damage circulating throughout her system. So what they found underestimates the DNA damage in the breast tissue itself. But doctors tell women there's nothing to worry about. Just a few extra cases of breast cancer are caused by mammograms. Wait, what? Mammograms causing breast cancer? Yes, the risk of radiation-induced breast cancer from modern, low-dose digital mammograms depends on how often you get screened and at what age you start. For a group of 100,000 women screened annually from age 40 to 55 years, and every other year until age 74, it's predicted that there will be 86 cancers induced and 11 deaths due to radiation-induced breast cancer, meaning they estimate 11 of those women will die from breast cancer that they would never have gotten if they decided not to get mammograms, not expose themselves to that radiation. They even calculated the lifetime risk of developing a radiation-induced breast cancer after just getting a single mammogram. Women with large breasts may carry additional risk because their mammograms may require additional views, and the greater radiation doses is expected to translate into a greater risk for radiation-induced breast cancer and breast cancer death. As much as triple the lifetime attributable risk of developing breast cancer because of the mammogram radiation exposure. The earlier one starts screening, the higher the risk as well, since there's more time for a cancer to grow. This comes up for women with BRCA gene mutations, for whom screening is sometimes recommended starting in their 20s. But at that age, mammograms may cause as many breast cancer deaths as they prevent. A net benefit would be expected at 35 years old, though, and likely the same for women without BRCA mutations. Yes, the risk of radiation-induced cancer from mammography is not negligible, but the potential for a mortality benefit is generally considered to outweigh the risk of death for radiation-induced breast cancer attributed to mammography screening, a benefit-to-risk ratio in lives of 10 to 1 or more. Now, these estimates on how much breast cancer mammogram X-rays may cause relies heavily on data from the atomic bomb survivors, who were exposed more to gamma rays, which are like high-energy X-rays. But it turns out the lower-energy X-rays used in mammography are even worse, approximately 4 times more effective in causing mutational damage than higher-energy X-rays. And since current radiation risk estimates are based on the effects of gamma rays, this implies that the risks of radiation-induced breast cancers for mammography X-rays is 4 times worse than previously estimated. But even if that were true, the benefit-to-risk ratio would still favor mammograms, which is why you see editorials in radiology journals like this. Concern about radiation exposure should not prevent a woman from undergoing life-saving mammography screening. But no trial has ever shown an overall mortality benefit from screening mammography. Thus, if there's a detrimental effect of radiation exposure from mammography, even a small effect could offset the benefits. While false positive results, pain during the procedure, and radiation exposure may be among the most frequent harms associated with mammogram screening, the most serious downside is now recognized to be something called overdiagnosis, so serious as to raise the question, does it make the whole thing worthless? The value of doing routine mammograms at all is being questioned due to overdiagnosis, which is the diagnosis and treatment of breast cancer that would never have become a threat to a woman's health or even apparent during her lifetime. See, people think that once you have a cancer cell in your body, it will progress predictably and inevitably to a terrible death. And that's simply not true of most cancers. Some cancers may outgrow their blood supply, become starved and wither away. Others may be recognized by our immune system and successfully contained. And some are simply not that aggressive in the first place. Meaning, yeah, it may continue to grow unchecked, but so slowly that it would be like 200 years before it was big enough to cause any problems, and so in effect, you die with your tumor instead of from your tumor. Indeed, if you do autopsy studies of young and middle-aged women who just happen to die in a car accident or something, 20% of them had cancer in their breast. So like 1 in 5 women are walking around with breast cancer. Now that sounds a lot scarier than it is, since at that age range the risk of dying from breast cancer is less than 1%. In fact, your risk of ever dying from breast cancer in your lifetime is less than 4%, which goes to show that many of these cancers they found incidentally, in fact most of them, would likely have just fizzled out on their own. The problem is we continue to have a 19th century definition of cancer, dating back to the 1860s. See, cancer is defined by what it looks like under a microscope, not by what its subsequent behavior is. So yeah, using that definition, 1 in 5 of these women technically had cancer, like this 30-year-old here, but that doesn't necessarily mean it would go on and do anything. The question then becomes, if it's so common, do you even want to know about it? If it's going to progress and cause a problem, then definitely. Catching it early could save your life. But if it's never going to grow, if it's going to remain microscopic, then finding it could actually be bad for you. They'd be like, look, you have cancer. We have to treat it, surgery, chemo, radiation, whatever it takes. Then you'd suffer all the physical effects of treatment, the psychological hell of fearing for your life, all completely unnecessarily, if in fact it was never going to cause a problem. That's overdiagnosis. These kinds of car accident-type autopsy studies show that between 7 and 39% of women ages 40 through 70 are walking around with tiny breast cancers. 30 to 70% of men older than 60 have prostate cancers, and up to 100% of older adults have microscopic cancers in their thyroid glands. Yet only 0.1%, 1 in 1,000, ends up suffering or dying from thyroid cancer. Normally it just sits there, doesn't do anything. Likewise, even though the majority of older men may have tiny cancers in their prostates, or a significant number of women in their breasts, the lifetime risk of death or cancer spread is only about 4%. So if you had a magic wand that could pick up cancer with 100% accuracy and waved it in front of people, your overdiagnosis rate, the probability that the prostate cancer you'd pick up would have turned out to be harmless, is like 90%. And nearly every single thyroid cancer, and a significant proportion of breast cancer cases. That's why screening for these cancers can be tricky, or even potentially dangerous, since in many cases, sometimes most cases, you have been better off if they had never found it. Now, this is not true for all cancers. There's little evidence of overdiagnosis for cervical or colorectal cancer, for example. Those cancers do seem to just keep growing, so the earlier you catch them, the better. So, institute pap smears, and cervical cancer death rates plummet. And just a single sigmoidoscopy between the ages of 55 and 65 may decrease one's risk of dying from colorectal cancer by up to 40%. Whereas some studies show that even getting mammograms every year don't appear to reduce breast cancer mortality at all. But if we assume a 15% drop and a 30% overdiagnosis rate, which is what most studies have found, then that would mean for every 2,000 women invited for mammograms for 10 years, 1 will have her life prolonged, and 10 healthy women would be overdiagnosed. In other words, they would not have had a breast cancer diagnosed if they had skipped screening, but were instead treated for breast cancer unnecessarily. And about 1,000 would have gotten false alarms, which can be stressful while you wait for the results. But the harms caused by becoming a cancer patient unnecessarily can be lifelong, and even mean a shorter life. It's important to be aware that some of the needlessly treated women will die from that treatment. For example, radiation treatments can't help but penetrate down into the heart as well, increasing the risk of the #1 killer of women, heart disease. This raises questions about doing routine mammograms, period, as it converts thousands of healthy women into cancer patients unnecessarily, some of whom may not make it out alive. Ironically, though, those who do become mammography's biggest cheerleaders, thinking mammograms saved their life. The mammogram found a cancer didn't even know you had. And yeah, the treatment was rough surgery, radiation, drugs, but it worked. Life was saved. Thank God she got that mammogram. You should too. Whereas actually, the more likely scenario, in fact, maybe the 10 times more likely scenario, is that the treatment didn't do anything, since the cancer wouldn't have hurt you anyway. So you went through all that pain and suffering for nothing. That's the crazy thing about mammograms. The people who are harmed the most are the ones who claim the greatest benefit. The evidence evidently clearly indicates that long-term marijuana use can lead to addiction. Approximately 9% of those who experiment with marijuana will become addicted, and that number goes up to about 1 in 6 among those who start marijuana as teenagers, and to 25 to 50% among those who smoke marijuana daily. By addiction, what they're talking about is like the colloquial definition, an acquired chronic relapsing disorder that's characterized by a powerful motivation to continually engage in an activity despite persistent negative consequences. You may want to stop, but when you try, you may suffer withdrawal symptoms that make it hard to quit. This withdrawal syndrome affects about 50% of daily users, and typically begins 1 to 2 days after stopping, peaks at 2 to 6 days, but the craving, sleeping problems, nightmares, anger, irritability, unease, and nausea goes away after 1 or 2 weeks. Marijuana now has this reputation as being benign, non-habit-forming, and that may be true for most users, certainly less addictive than many other drugs like alcohol, only about half the dependence risk compared to heroin or cocaine, less than a third as habit-forming as tobacco, but 9%, 1 in 11 users, 1 in 6 for those starting in their early teens, is hardly an inconsequential percentage, given that about 20 million Americans actively use the stuff. However, not all varieties of cannabis are equally addictive. High-potency strains have been associated with a greater severity of dependence, but that's the stuff people prefer. This is not your grandmother's grass. Based on 38,000 samples of marijuana confiscated by the DEA, the potency has tripled in recent years, from 4% THC up to around 12%, with Denver and California now up around 15, and Seattle pushing 20. That's 15 times more powerful than pot from the 70s, so like 15 joints all rolled up into one. Yeah, but don't users know this and titrate their dose accordingly, using less of the more potent pot? Yes, but they don't compensate fully, and so do end up getting higher doses, perhaps reflected in the increase in emergency room visits in Colorado for marijuana intoxication after legalization. Parallels have been drawn with the tobacco industry, intentionally boosting nicotine levels of their products to make them more addictive. But where that analogy breaks down is in the consequences of that addiction. Every year, tobacco kills 25 times more people worldwide than all illicit drugs combined. Alcohol kills about 10 times more, and cannabis alone probably contributes little to overall mortality, at least. So one has to consider the outcomes of substance dependence. Caffeine can be addictive too, but if it gets you to drink more green tea, then great. The consequences of consuming this leaf as opposed to this leaf depends on the health consequences. The popular notion seems to be that marijuana is a harmless pleasure. But what are the potential adverse effects of marijuana use? That's not an easy question to answer. Most studies to date have been cross-sectional, or rely on self-reported health. Cross-sectional means a snapshot in time, so you don't know which came first. Are people sick because they're smoking marijuana, or are they smoking marijuana because they're sick? If you just ask people how they are, pot smokers may be like, "I feel great," even if they're actually suffering from some health problem. Few longitudinal studies have been done, meaning studies done over time using objective measures of health, until now. More than 1,000 individuals followed up from birth to age 38, testing associations between cannabis use over decades and multiple domains of physical health. They looked at 12 health outcomes, and tobacco use was associated with worse health for 8 of 12, from impaired lung function to systemic inflammation and metabolic derangements, and cannabis use was associated with just gum disease. That's it? Cannabis use was unrelated to other physical health problems. Now, periodontal disease can lead to tooth loss, and there may be other dental health problems associated with smoking marijuana, but when cannabis is described as nefarious, the first thing to come to mind is probably not gingivitis. Is it possible that cannabis users are just living healthier than average lifestyles to counteract the effects of the drug, like eating more fruits and vegetables, or maybe drinking less alcohol? No, neither are pot smokers exercising anymore, and so the absence of associations between cannabis use and poor physical midlife health could not be attributed to any of these other things, so maybe marijuana is just not that bad. Heroin may increase your risk of dying. Cocaine use may increase your risk of dying, but no association was found between mortality and marijuana. Now, they did just follow these folks until age 38. To find out what happens after that, we need to turn to Sweden, where they recently published the longest study ever on cannabis and mortality. 50,000 men followed up to around age 60. About 30 years ago, when they first reported on this cohort, no significant excess mortality was found among cannabis users, or abusers, as they called them. But back then, these men were in their 30s, like in that other study. What happens when you follow them past middle age, when perhaps the health-related detrimental effects might begin to emerge? Those with a history of heavy cannabis use did end up having a significantly higher risk of death, a 40% higher risk of dying prematurely. But wait a second, I thought cannabis didn't kill. Cocaine kills thousands of Americans every year. alcohol kills tens of thousands, and tobacco breaks the graph, wiping out hundreds of thousands of people in the U.S. every year, but marijuana doesn't even make it onto the graph. But what they're referring to is that no deaths have been directly attributed to the acute physical toxicity of cannabis. So when some 19-year-old eats a cannabis cookie and then jumps off the fourth-floor balcony, the direct cause of death was the fall, but that doesn't mean cannabis didn't contribute. It's true that people don't directly OD on cannabis like you can with opiates, which can shut down your breathing. Unlike many pharmaceuticals, for which a harmful dose may just be a few times larger than the prescribed dose, the therapeutic index for cannabis is like 40,000 to 1. Does that mean you could smoke like 40,000 joints without ODing? No. You may be able to smoke 2 million joints before a lethal overdose. Cannabis use contributes more to disease than death, in part because people aren't injecting it. But the health-related harms of cannabis had never been quantified on a global scale until 2013. Every year, cannabis is estimated to result in 2 million years of healthy life lost due to disability. Now, this is tiny compared to 100 million or so years attributed to alcohol or tobacco, but still results in a lot of pain and suffering. But what about our gum disease study? I thought the only physical health problems were dental in nature. Well, they were just looking at a specific set of health problems. They emphasized that the periodontal problems are in addition to all the other potential issues, like increased risk of accidents and injuries, bronchitis, heart attacks, and strokes, possibly infectious diseases, and cancer, as well as the mental health concerns. But in terms of as a more direct cause of death, marijuana may be suspected in maybe hundreds of deaths over an 8-year period, whereas a single pharmaceutical drug, Viagra, was involved in thousands. The whole point of cancer screening is to detect life-threatening disease at an earlier, more curable stage. So an effective cancer screening program would therefore increase the incidence of cancer detected at an early stage, because you'd find all those tiny cancers you would have missed before, and therefore decrease the incidence of cancer preventing at a late stage, because you would have cut out all the little cancers you found, pulling them out of circulation. But that's not what appeared to happen with mammograms. As mammography ramped up in the 80s, the first part happened, the diagnosis of early cancer shot up. And so what we'd like to see is like a mirror image of this going the other way for late-stage cancers. If you caught it early, it wouldn't be around for late. But that didn't happen. Late-stage cancer incidence didn't seem to drop much at all. Another way to look at this is to compare mammogram rates around the country. The more mammograms you do, the more heavily screened the population is, the more early cancers you pick up. Great. And late advanced disease should go down too, right? But it doesn't. We're taking all these early cancers out of circulation, surgery, radiation, so there should be about the same number of fewer late-stage cancers found, but that didn't happen. Mammograms catch a lot of small cancers, but with no concomitant decline in the detection of larger cancers. That would explain this. The more mammograms you do, the more cancer you find, but death from breast cancer doesn't seem to change much. Oh, wait a second, you just cut out tens of thousands of cancers. Why aren't there that many fewer women dying? Together, these findings suggest widespread overdiagnosis, meaning cancer picked up on mammogram that would have never progressed to the point of presenting during the woman's lifetime, and so wouldn't even have been noticed or caused any harm had it never been picked up at all. So if removing all these early ones didn't lead to that many fewer late ones, that suggests that most would have never progressed during that time, or even go away on their own. That could explain almost all that increase in incidence, and indeed, many invasive breast cancers detected by repeated mammography screening do not persist to be detected later, suggesting that the natural course of many of the mammogram-detected invasive breast cancers is to spontaneously regress, spontaneously disappear. We've known for more than a century that even serious metastatic breast cancer can sometimes just spontaneously go away. The problem is that you can't tell which is which. So if you find it, the natural inclination is to treat it, which can be especially tricky for ductal carcinoma in situ, DCIS, so-called stage 0 breast cancer. This is what it looks like. Ductal means in the breast ducts, carcinoma means cancer, and in situ means in place, in position, not spreading outside the duct. And it can create these tiny calcifications that can be picked up on mammogram. The whole point of mammograms was to identify early invasive disease, so the large numbers of DCIS they found were unexpected and unwelcome. Prior to the advent of mammogram screening, DCIS made up approximately 3% of breast cancers detected, but now accounts for a significant chunk. The cells look like invasive cancer, and therefore the presumption was made that these lesions were the precursors of cancer, stage 0 cancer, and that early removal and treatment would reduce cancer incidence and mortality. However, long-term population studies have demonstrated that the surgical removal of 50,000 to 60,000 DCIS lesions annually has not been accompanied by a reduction in the incidence of invasive breast cancers. This is in contrast to our experience with removing colon polyps with colonoscopy, or precancerous cervical lesions thanks to pap smears, in which the removal of precursor lesions has led to a decrease in the incidence of colon and cervical cancer. Those are cancer screening programs that work. Radiologists argue that overdiagnosis isn't so much the problem as overtreatment. Yeah, it sucks to get a breast cancer diagnosis, even though it would have never hurt you, but you don't know that at the time, so most women undergo aggressive surgical and radiation treatment. Yeah, but if you compare the 10-year breast cancer survival for women with low-grade DCIS among those who chose not to go to surgery at all, 1.2% of them died of breast cancer within a decade. But in that same decade, those that went to surgery instead for a lumpectomy or a full mastectomy to cut it out, 1.4% died from breast cancer. So surgery appeared to make no difference. That's why there are currently randomized controlled trials to put it to the test. But it's incredibly difficult to convince a patient with DCIS not to just want to get it cut out. The fear of cancer paralyzes patients who may resort to drastic, excessive measures like getting a double mastectomy. How can we prevent that? How about we change its name? A National Cancer Institute panel has recommended dropping the carcinoma part. Let's just call it an indolent lesion of epithelial origin. Use language that engenders less fear. How bad can an idle tumor be? Another option to avoid this dilemma is just not get screened in the first place. But women aren't typically told about any of this. Less than 1 in 10 women were aware that mammograms carried any potential harms at all, and more than 9 out of 10 were unaware that some breast cancers never cause problems. Few were told about DCIS, but when informed about it, most wished they were told before they signed up. Once a cancer is detected, it's currently not possible to distinguish life-threatening from potentially harmless cases. Therefore, overdiagnosis can only be avoided by abstaining from routine mammograms altogether. That's how this researcher explained her own decision away from screening, worried by the possibility that she could be seriously harmed by the treatment of a cancer that would have never affected her health. Given that the only way to avoid opening that Pandora's box is by not getting mammograms, instead, she decided to try improving her diet and lifestyle to prevent getting breast cancer in the first place. Fueled by good intentions and economic conflicts of interest with the multi-billion-dollar mammogram industry, many women are being given diagnoses of breast cancer unnecessarily, producing unwarranted fear and stress and exposing them to treatment they don't need. This is the overdiagnosis problem I've been talking about, the detection of pseudo-disease. Mammogram-detected abnormalities that look like cancer under a microscope, and so you're diagnosed with cancer, you're treated for cancer, but it was just pseudo-disease and would have never progressed to actually cause symptoms. The human costs include mastectomies and even deaths. The chance that a woman will benefit from mammograms may be small, in fact, maybe 10 times smaller than the risk that she may experience serious harm in terms of this overdiagnosis. How many would elect to go in for a mammogram if they knew that for every one woman who is notionally saved by early detection, anywhere from 2 to 10 otherwise healthy women are being turned into breast cancer patients unnecessarily? Well, first of all, are patients even told about the possibility of overdiagnosis by their physicians? I mean, it is, after all, now recognized as the most serious downside of mammogram screening. Well, hundreds were asked, and less than 1 out of 10 said that they'd been informed about it. And when they were told about it, a little more than half said they wouldn't agree to screening if it resulted in more than one overtreated person per life saved. Wow, that implies that millions of Americans might not choose to be screened if they knew the whole story. However, 90% do not. Most women are aware about false positives and tend to view them as an acceptable consequence of mammograms. But in contrast, most women were unaware that screening could detect cancers that may never progress, and what they don't know could potentially even kill them. So when considering the pros and cons of mammograms, it would be good to consider total mortality. It can actually help you live longer on average. And mammograms have not been shown to do that. It's therefore misleading to claim that screening saves lives. Theoretically, a routine mammogram should increase a 50-year-old non-smoking woman's overall survival chance from around 96.3% to 97.1% over 10 years. But these statistics disregard deaths from overdiagnosis, deaths from the unnecessary radiation and chemo, and thus increased mortality from heart disease and other cancers that may entirely outweigh the benefit in terms of reduced breast cancer mortality. You can't irradiate the breast without exposing the rest of your chest to radiation, your heart, your lungs, explaining why breast cancer survivors can end up with significant and marked impairment in cardiopulmonary heart-lung function. Radiation treatments increase deaths from heart disease by more than 25%, and from lung cancer by nearly 80%. Now, we would accept that risk if we were beating back some deadly cancer, but the main effect of screening is to produce patients with breast cancer for which treatment offers zero benefit, since they would have remained free of breast disease for the rest of their lives without it, since compelling data suggests that most overdiagnosed tumors would have regressed spontaneously without treatment. Still, women who have had a cancer detected and then removed are likely to feel their life was saved, but perhaps 10 times more likely their lives were actually seriously harmed, not saved. 10 times more likely you were told you had a cancer that could kill you, but you really didn't. Corralled into the operating room for surgery you didn't need. Every doctor's appointment, every sleepless night, all completely unnecessary, yet you come out as mammogram's greatest advocate. It saved your life. That's the crazy thing about mammograms, about PSA testing for prostate cancer. The people who are the most harmed are the ones who claim the greatest benefit. So overdiagnosis creates this vicious cycle for more overdiagnosis, because more and more people know someone, a friend, family member, celebrity, who owes their life to early cancer detection. So the worse the test is, the more overdiagnosis it causes, the more popular it becomes. The more mammograms harm women, the better they seem to work. The more breasts that are surgically removed completely unnecessarily, the more women swear by it. Yeah, it's maybe billions of dollars wasted for nothing that could be spent on doing more for women's health, but it's the human cost. The harms from breast cancer screening may outweigh the benefits if death caused by treatment is included. Based on some best and worst case scenario estimates, for every 10,000 women invited for 10 years of mammogram screening, 3 to 4 breast cancer deaths may be avoided, at the cost of around 2 to 9 deaths from the long-term toxicity of unnecessary radiation treatments. Yet only 1 in 10 women undergoing mammography said they were ever told about overdiagnosis, even though 9 out of 10 thought they had the right to know. Now, overdiagnosis is not easy to talk about. It's a sensitive issue. But just because communicating with patients can be difficult doesn't mean that we shouldn't do it. Informed women deserve no less. We have an ethical responsibility to let them know. Are men talking their reproductive health away? There have been unexplained declines in semen quality reported in several countries. Might cell phones be playing a role? as radiofrequency electromagnetic radiation from these devices could potentially affect sperm development and function. The cell phone industry bristles at the R word, radiation, preferring the more innocuous-sounding RF EMFs. They do have a point, though, about it being used by snake oil hucksters of radiation protection gadgets. Radiation need not be atomic bomb gamma rays, but just the warm glow of sunshine on your face. That's radiation, too. The question is, does the specific type of radiation emitted by cell phones affect male fertility? After the World Health Organization declared that cell phones could possibly cause brain cancer, many folks were like, no problem, I'll just keep them in my pants and use Bluetooth or something, away from the brain, but close to the gonads. Put all the studies together, including nearly 1,500 semen samples, and exposure to mobile phones was associated with reduced sperm motility and viability, though not necessarily sperm concentration. How much less could they swim? Sperm motility only appeared to be about 8% less, and so that alone may not actually translate into reduced fertility, unless you're starting out with a marginal sperm count in the first place. So especially for men who already have fertility problems, it might be better to avoid keeping an active cell phone next to your crotch for long periods of time. Cell phones may just be one of a bunch of things that could potentially add up. For example, Wi-Fi may be an issue, so researchers got semen samples from more than 1,000 guys, and the total number of swimmers, motile sperm, were decreased in a group who used wireless internet. OK, but these were all just observational studies. Maybe men who use Wi-Fi just tend to smoke more, or do more horseback riding or something, and that's the reason for the apparent link. You don't know until you put it to the test. Unfortunately, many of the studies are like this, on rats. So while the microwaves emitted from a cell phone do not appear to affect rat testicles, it can be argued that you can't necessarily extrapolate from these animal models since, for example, their scrotums are non-pendulous, meaning their testicles are more inside of their bodies rather than out swinging around. So, at least until proven otherwise, it's recommended that men with fertility issues may not want to keep their cell phones in their front pants pocket in close proximity to their testicles. Even when not in use, cell phones emit radiation to keep pinging their location, though the main exposure is during talk mode, where it may still remain in the pocket thanks to headsets these days. And then what happens when you have it in proximity to other common metal objects? Here's a cross-section at crotch level. There's the phone. You may have a metal zipper, key ring in your pocket. When all three objects were added, the SAR, the amount of radiation absorbed into the testicles, was generally increased, even approximately doubled. But that's only a problem if the radiation does actually damage sperm. How hard is it to just design a study where you just wave a cell phone over some human sperm in a petri dish to see if it's an issue? And here we go. Significantly more DNA fragmentation in sperm exposed to cell phone radiation, starting within an hour of exposure. Such a dramatic effect that they suggest women might not want to pocket their cell phones for a few days after trying to get pregnant so as to not put the sperm at further risk. It's impossible to imagine a modern, socially active man who does not use cell phones and Wi-Fi. Might that be harmful for male fertility? In my last video, I talked about how the sperm of men who use Wi-Fi tend to not be getting along as swimmingly well, but that was an observational study. We don't really know if Wi-Fi actually damages sperm until you put it to the test. The title kind of gives it all away, but basically, this was the first study to evaluate the direct impact of laptop use on human sperm. Here's the DNA fragmentation in samples near and far away from a laptop with an active Wi-Fi connection, suggesting one might not want to position a Wi-Fi device near the male reproductive organs. Yeah, Wi-Fi exposure may decrease human sperm motility and increase sperm DNA fragmentation, but the effect is minor. Is having 10% fewer good swimmers really going to make a difference? Fertile men release hundreds of millions. What is yet to be done is a study looking at bouncing baby endpoints. Do men randomized to a certain exposure have a tougher time having children? It's actually a harder study to perform than one might think. You can't just have men avoid cell phones and laptops for a day. Yes, we make millions of new sperm a day, but they take months to mature. The sperm with which you conceive today started as a preconceived notion months before. So you can imagine why such a study has yet to be done. You'd have to randomize men to essentially avoid wireless communications completely, or maybe come up with some kind of Faraday cage underwear. Another reason why one may not want to use a laptop computer on your lap is just the heat generated by the laptop itself, Wi-Fi or not, can warm men's scrotums, undermining the whole point of scrotum possession in the first place. This all dates back to a famous series of experiments back in 1968. It was an illuminating study, one might say. Sometimes they'd add a reflector to boost the heat, though the bulb alone was just as effective, but they had to move it closer to the skin. Much simpler, but more likely to result in a Jerry Lee Lewis song.
Balls of fire.
But now we have nice cool fluorescence, but heated car seats remain a testicular heat stress factor. Saunas aren't a good idea for men trying to conceive. Sperm counts before and after, apparently cutting sperm production in half, and still down 3 months later, but apparent full recovery by 6 months. But that's why boxers, not briefs. Or go all commando. Who makes money on that, though? That's why we need a scrotal cooling device industry, though this review noted that more acceptable scrotal cooling techniques really need to be developed. Why? Whatever are they referring to? It seems the devices currently on the market are not so practical day to day. There's the curved rubber collar filled with ice cubes. Another was just like a freezer gel pack inserted into the guy's underwear every night. Not to worry, though, it thaws in 3 to 4 hours tops. Holy snowballs, Batman. Do not, I repeat, do not put an ice pack on your scrotum. A few frozen peas and carrots, and you can frostbite yourself. See, sometimes even vegetables can be bad for you. Then there's the Schwitzer that keeps the scrotum damp. And finally, attached with a belt, achievement of scrotal cooling with a continuous airstream. With so many options to choose from, do laptop users really need protection from scrotal hyperthermia? You don't know until you put it to the test. And indeed, an increase in scrotal temperature was found in laptop computer users. Scrotal temperatures up a feverish 5 degrees Fahrenheit. A little scrotal warmth doesn't sound that bad, though. Then I read this case report. A previously healthy 50-year-old scientist typing out a report one evening, sitting comfortably in his favorite chair, laptop in lap, but woke up the next day with blisters, penile and scrotal blisters, that then broke and developed into infected wounds that caused extensive oozing pus. Even third-degree burns have been reported, requiring surgical intervention with skin grafts. The guy drank 12 units of vodka and passed out while watching a film on his lap, and the laptop burned through his leg. The surgeons call for a public education campaign to educate the public against the risks of using a laptop in its most literal sense. How about instead educating the public against drinking 12 units of vodka? While running for President of the United States, former New York Mayor Rudy Giuliani ran a campaign ad contrasting his chance of surviving prostate cancer in the U.S., 82%, with the same chance of surviving prostate cancer in England, only 44% under socialized medicine, where they don't do routine PSA testing for prostate cancer. To Giuliani, this meant that he was lucky to be living in New York rather than Old York, because his chances of surviving prostate cancer seem to be twice as high here in the U.S. Yet despite this impressive difference in this 5-year survival rate, the mortality rate, the rate at which men were dying of prostate cancer, was about the same in the U.S. and the U.K. Wait, what? PSA testing increased survival from 44 to 82%. How is that not evidence that screening saved lives? For two reasons: lead time bias and overdiagnosis bias. I've talked about overdiagnosis, where a cancer is picked up that would otherwise have never caused a problem. Without screening, let's say out of 1,000 people with progressive cancer, only 400 are alive 5 years later. So without screening, 5-year survival, only 40%. But let's say with screening, an additional 2,000 cancers are overdiagnosed, meaning you picked up cancers that would have never caused a problem, or even would have disappeared on their own. Since the cancer was harmless, 5 years later, of course, they're all still alive, assuming their unnecessary cancer treatment didn't kill them, and all of a sudden, you just doubled the 5-year survival rate, even though in either case the same number of people died from cancer. And that's one way how changes in survival rates with screening may not correlate with changes in actual cancer death rates. The other is lead time bias. This is how it works. Imagine a group of patients in whom cancer was diagnosed because of symptoms at age 67 years, all of whom die at age 70. Each patient survives only 3 years, so the 5-year survival for this group, 0%. Now imagine that same group undergoes screening. Screening tests, by definition, lead to earlier diagnosis. Suppose that with screening, cancer is diagnosed in all patients at age 60 years, but imagine in this case they nevertheless all still die at age 70 years. In this scenario, each patient survives 10 years, so the 5-year survival rate for this group is 100%. Survival just went from 0 to 100%. Call the newspapers. With this new screening test, now cancer patients are living 3 times longer, 10 years instead of 3. It's a miracle. Whereas all that really happened in this case was that the person was treated as a cancer patient for an additional 7 years, which, if anything, probably just diminished their quality of life. So that's the second way how changes in survival rates with screening may not correlate with changes in actual cancer death rates. And in fact, the correlation is 0. There is no correlation at all between increases in survival rates and decreases in mortality rates. That's why, if there were an Oscar for misleading statistics, using survival statistics to judge the benefit of screening will win a Lifetime Achievement Award, hands down. There is no way to disentangle the lead time bias and the overdiagnosis bias from screening survival data. That's why these statistics are meaningless when it comes to screening. Yet that's what you see in the ads and the leaflets for most of the cancer charities. That's what you hear coming from the government. Even prestigious cancer centers like MD Anderson have tried to hoodwink the public like that. If you've never heard of lead time bias, don't worry, you're not alone. Your doctor may not have either. 54 of 65 physicians surveyed said they did not know what lead time bias was, and then when they asked the remaining 11, OK, what is it? Only 2 were actually correct. So at this point in the video, already you may know more about this than 97% of doctors. To be fair, though, maybe they don't recognize the term but understand the concept. Nope. The majority of primary care physicians did not know which screening statistics provide reliable evidence on whether screening works. They were 3 times more likely to say they would definitely recommend a cancer screening test based on irrelevant evidence, compared to a test that actually decreased cancer mortality by 20%. If physicians don't even understand key cancer statistics, how are they going to effectively counsel their patients? Statistically illiterate physicians are doomed to rely on their statistically illiterate conclusions, or on local customs, or on industry representatives and their information. Critics of mammogram breast cancer screening claim that on a population scale it's never been shown to actually prolong women's lives on average. But look at this clear drop in breast cancer mortality in the UK right when routine mammograms were introduced. Same here in Denmark, a nice drop in breast cancer mortality right after screening started. That didn't appear to be the case in Switzerland, though, where breast cancer mortality was declining years before routine mammograms were introduced. So let's go back and look at that UK graph. It's tempting to conclude that breast cancer screening caused the drop, but it is a little suspicious that the drop happens immediately. I mean, you'd expect it to take a few years to manifest, and if you split it up by age group, the whole thing falls apart. Here's what the graph looks like. And this is the only age group that started screening at that time. So there were drops in other age groups, too, that weren't getting mammograms. Same with the Denmark data. This is the line for the areas that got screened. This is the line for the areas that didn't get screened. You see the same drop in breast cancer mortality with or without. What's going on? Here's the U.S. data. Looks just like that UK graph, where there's this beautiful drop in breast cancer mortality right when mass mammograms were introduced around 1990. But check it out. The same drop, in fact even more, among women getting less screening, and an even greater drop in breast cancer mortality among women not getting mammograms at all. In other words, there was a larger relative reduction in breast cancer mortality among women who were not exposed to screening mammography. So what happened? The decrease in mortality is probably largely the result of improved treatment, not screening. Breast cancer mortality started dropping all around the world at about the same time. Regardless, when mammogram screening started, there's no relation at all between start of screening and the reduction in breast cancer mortality. The declines are more likely explained by the introduction of the estrogen-blocking drug tamoxifen. You can see it really clearly in the U.S. data, with breast cancer death rates plummeting in the United States after FDA's tamoxifen approval in 1990. Now, this doesn't mean breast cancer screening isn't playing some role, and in fact, randomized controlled trials have shown that routine mammograms may reduce breast cancer mortality by 20%. Now, that 20% drop is from like 5 in 1,000 women dying during that time from breast cancer without screening, down to 4 in 1,000 dying with screening. And so when you graph it, it doesn't look that impressive. The red line is the risk of dying for women that are invited for routine screening, and the green line is the risk of dying for women not getting mammograms. They're practically right on top of one another. And this is assuming mammograms don't increase deaths from other causes. If we take into account the cardiac and lung cancer deaths caused by radiation treatments in women overdiagnosed with pseudo-disease and treated with cancer unnecessarily thanks to mammography, there doesn't appear to be any overall mortality benefit. Why aren't mammograms more effective? It seems so simple. Catch the disease early, right? Turns out, by the time breast cancer is caught by mammogram, it may have already been growing for literally decades. It's therefore misleading to say breast cancers are caught early with screening. They may actually be caught very late. Without mammograms, breast cancer may not be caught for 22.8 years, but with mammograms, breast cancer may only grow and spread for 21.4 years. No wonder mammograms don't do a better job at preventing breast cancer deaths if the cancer can spread before you can cut it out. Concerns have even been raised that the trauma from surgery may accelerate the growth of any cancer left behind, and maybe that would help explain why there's not more benefit to screening. Regardless, 9 out of 10 women may still be in the dark, overestimating the mortality reduction from mammography screening by like an order of magnitude, tenfold or more. About the same percentage of men thought the same thing about prostate cancer screening, vastly overestimating the benefits or simply not knowing. Only 1.5% of women surveyed were in the ballpark. Ironically, those reporting frequently consulting with their physicians, reading health pamphlets, did even worse, overestimating the benefits even more, raising a question that was asked decades ago by a director of a mammogram project as she lay on her deathbed before succumbing to breast cancer herself, realizing even back then that routine mammograms may not actually be saving women's lives. She asked, "Are we brainwashing ourselves into thinking that we're making a dramatic impact on a serious disease before we brainwash the public?" In the mammography wars, rational thinking can be easily lost. Yes, mammograms are big business, bringing in about $7 billion a year, but it'd be a bit too cynical to believe that the pushback from mammogram critics stems only from the self-interest of radiologists and breast surgeons whose daily bread depends on the continuation of routine mammogram screening. It just makes intuitive sense that mammograms should work, but that's why we have science, so we can put things to the test. We owe it to our patients to be evidence-based rather than faith-based. They deserve an objective analysis of the data. We've done a dismal job of accurately informing the public, and the question is why? Well, one reason is that the doctors themselves aren't informed. For example, a survey of radiologists found that 96% overestimated a middle-aged woman's risk of breast cancer. In one sneaky study, researchers called up gynecologists and pretended to be a concerned family member, asking for a phone consultation about the benefits and harms of mammograms. Although all the gynecologists appeared motivated and concerned with sufficiently answering our questions, they simply appeared to lack the information, as well as knowledge of how to communicate information on medical risk. When doctors meet numbers, we cannot take for granted the ability of physicians to understand and interpret data and use it to the best advantage of the patient. An educational blind spot for physicians identified more than 80 years ago. In this study, for example, 151 practicing physicians were asked a series of multiple choice and true and false questions to gauge their practical understanding of some key concepts. And they failed miserably, only got 55% correct, only about 20% more than they would have gotten just randomly guessing. If doctors don't understand health statistics, how can they possibly counsel patients properly? There was a famous study in which 100 physicians were asked what the chances were of a woman actually having breast cancer if her mammogram came back positive. They gave them all the numbers so they could do the math. And 95 out of 100 not only got it wrong, but spectacularly wrong, off by 1,000%. Even doctors at Harvard had a problem. Faculty, staff, and students at Harvard Medical School were asked a simple question, and 82% got it wrong. That was a few decades ago, though. In an updated survey in Boston, only 77% got it wrong, an average of about 3,000% off, demonstrating medicine's continued discomfort with math. Only 12% of thousands of OBGYN residents were able to correctly answer two simple questions on medical statistics. What will the uninformed 88% of these residents say when their first patient asks about her chance of truly having breast cancer given a positive mammogram? And what's particularly frightening is that in some studies, those doctors most confident in their estimates were furthest away from the correct response, so they didn't even know that they didn't know. All these studies document the same phenomenon. A considerable number of physicians are statistically illiterate. That is, they do not understand the statistics of their own discipline. So when physicians say they don't have time to fully inform patients about the benefits and harms of a test, maybe that's a good thing, if they don't know what they're talking about. Instead, they may just talk about the benefits and skip the whole harms part, and so we shouldn't be surprised when 9 out of 10 women say, "Harms from mammograms? What harms?" while often greatly overestimating the benefits, whereas in fact the benefits and harms may be so evenly balanced that maybe we should just inform women and let them make up their own minds. But that's not what you hear from ad campaigns. They just tell women to do it, overstating the benefits, sometimes ignoring harms altogether, using persuasion instead of education, fear, guilt, whatever it takes. It's easy to sell screening, just magnify the benefit, minimize the harms, keep the actual numbers under wraps. I mean, studies have randomized hundreds of thousands of women to get mammograms or not, to put it to the test. What's the point if we're not going to share the results? We spend billions on these clinical studies, but fail to ensure that patients and physicians are communicated the results in a transparent manner. Maybe women should tear up the pink ribbon and campaign for honest information. How else can women make informed decisions? Instead, we get hospitals putting on like mammogram parties. Maybe in addition to the appetizers, they should serve women balanced information to chew on as well. When it comes to cancer screening, doctors have too often ignored the fact that women may place different weights on various pros and cons, and just focused on persuading rather than educating, to let people make up their own mind. To do that, though, they need some quantification of its benefits and harms in a clear and accessible format. Enter fact boxes. For example, In 2014, German physicians recommended transvaginal ultrasounds to millions of women to screen for ovarian cancer, in which a probe like this is inserted. They'll look around. OK, but what does the science say? Based on a study of hundreds of thousands of women, if you randomize 1,000 women to get vaginal ultrasounds and 1,000 women to skip them, and then follow them out for a decade or so, 3 of the women who skip the screening will die from ovarian cancer. But the same number died with the screening, so there was no benefit at all. Instead, 32 of them went into surgery to have their ovaries removed because something looked suspicious on the ultrasound, but turned out to be totally unnecessary. And one of those women suffered surgical complications, all for naught, just harms, no benefits. Yet millions of women were subjected to the probing, probably resulting in more than 10,000 women having healthy ovaries removed in just 1 year. A boon for the hospitals and the surgeons and their local BMW dealers, but just pain and suffering for the women. What would a fact box for mammograms look like? Each of these gray circles represents one woman, 1,000 randomized to skip mammograms, and 1,000 randomized to get mammograms. After a decade in the no-screening group, about 5 out of the 1,000 women will die from breast cancer. So even without screening, the chances of dying from breast cancer in one's 50s is less than 1%. But by getting regular mammograms, instead of 5 out of 1,000 women dying from breast cancer, only 4 in 1,000 will die from breast cancer, though the number of women dying overall appears to be the same either way. So no lives are necessarily saved overall, but maybe the studies just haven't had the statistical power to pick up on an overall survival benefit. In terms of harms, 100 of the women getting mammograms will be called back in for false alarms and maybe even biopsied, and 5 will have unnecessary lumpectomies or mastectomies. A third potential harm, getting radiation-induced breast cancer from the mammograms themselves, not included, because only rough indirect estimates exist, and it may only be like 1 in 10,000 women. Here's a graphical representation. This is over a 20-year period, so women following the current USPSTF recommendation to get screened every other year starting at age 50, one would expect 200 false alarms over those 2 decades. But only about 30 would end up being biopsied. It would miss a few cancers, but in 15 cases find too many women diagnosed with and treated for breast cancer unnecessarily. But on the other hand, 2 breast cancer deaths would be averted thanks to mammograms, though no overall lives will apparently have been saved. Not everyone agrees with these numbers, though. Here's the most optimistic numbers I could find per 1,000 women screened. Up to 10 times the benefit getting mammograms every year for 25 years starting at age 40, at the cost of an average of 3 false alarms each, a 1 in 3 chance of getting a biopsy, and about a 1% chance of being diagnosed and treated for breast cancer unnecessarily. Now, this is assuming asymptomatic women at average risk. Women at higher risk, like those who've already had breast cancer or have BRCA gene mutations, would be expected to benefit much more. But for the average woman, there's simply no right answer to whether a woman should undergo mammographic screening. It should be left up to each woman to make up their own mind. We hope that the data presented will help with that decision. Some may choose to pursue screening, valuing any potential for benefit as warranting the accompanying harms. Others may choose not to, feeling the potential harms may be just too great to justify the benefits. Regardless, how about trying to not get breast cancer in the first place? Individuals may rather be told to get a quick test every few years than to be told to eat well and exercise to prevent cancer before it starts. Screening has become an easy way for both doctor and patient to think they're doing something good for their health, but getting screened for cancer doesn't change the risk of getting cancer in the first place. And not just cancer, the same diet and lifestyle that can protect against cancer can also protect against the leading killer of women. Here's the number of women dying from breast cancer versus the number of women dying from heart disease. And while mammograms may not save lives, we know that lifestyle modifications to prevent heart disease can. So maybe some of those billions spent every year on mammogram programs could be better spent saving the lives of women. If I'm asked at a lecture whether some food is healthy or not, my reply is Compared to what? For example, are eggs healthy? Compared to some breakfast sausage next to it? Yes. But compared to oatmeal? Not even close. Think of it as having $2,000 in your daily calorie bank. How do you want to spend it? For the same number of calories, you can eat one Big Mac, 50 strawberries, or a half a wheelbarrow full of salad greens. Now, they don't exactly fill the same culinary niche. I mean, if you want a burger, you want a burger, and I don't expect quarts of strawberries to make it onto the dollar menu anytime soon, but it's an illustration of how mountainous a nutrition bang you can get for the same caloric buck. Every time we put something in our mouth, it's a lost opportunity to put something even healthier in our mouth. So what are the best foods to eat and the best foods to avoid? Here's how I like to think of it. This is my traffic light system to help quickly identify some of the healthiest options. Green means go, yellow means caution, and red means stop, and think before you put it into your mouth. Ideally, on a day-to-day basis, green category foods should be maximized, yellow foods minimized, and red category foods avoided. As far as I can figure, the best available balance of evidence suggests the healthiest diet is one that maximizes the intake of fruits, vegetables, legumes, which are beans, split peas, chickpeas, and lentils, whole grains, nuts and seeds, mushrooms, herbs and spices, basically real food that grows out of the ground. These are our healthiest choices. In general, the more whole plant foods and the fewer processed and animal foods, the better. So more green light foods and less yellow and red. Like running red lights in the real world, you may be able to get away with it once in a while, but I wouldn't recommend making a habit out of it. My traffic light model stresses two important concepts. Plant foods tend to be healthier than animal foods, in terms of being packed with protective nutrients and fewer disease-promoting factors. And unprocessed foods tend to be healthier than processed foods. Is that always true? No. Am I saying that all plant foods are better than all animal foods? No. In fact, the worst thing on store shelves has been partially hydrogenated vegetable shortening. It's even got vegetable right in the name. Even some unprocessed plants, such as blue-green algae, can be toxic. Anyone who's ever had a bad case of poison ivy knows plants don't always like to be messed with. In general, though, choose plant foods over animal foods and unprocessed over processed. What do I mean by processed? The classic example is the milling of grains from whole wheat, for example, to white flour. Isn't it ironic that these are then called refined grains, a word that means improved or made more elegant? The elegance was not felt by the millions who died from beriberi in the 19th century, a vitamin B deficiency disease that resulted from polishing rice from brown to white. White rice is now enriched with vitamins to compensate for the refinement. A Nobel Prize was awarded for the discovery of the cause of beriberi and its cure, rice bran, the brown part of rice. Beriberi can cause damage to the heart muscle, resulting in sudden death from heart failure. Surely such a thing could never happen in modern times. I mean, an epidemic of heart disease that could be prevented and cured with a change in diet? Check out my videos on heart disease. Sometimes, though, processing can make foods healthier. For example, tomato appears to be the one common juice that may actually be healthier than the whole fruit. The processing of tomato products boosts the availability of the antioxidant red pigment by as much as 5-fold. Similarly, the removal of fat from cacao beans to make cocoa powder improves the nutritional profile, since cocoa butter is one of the rare saturated plant fats, along with coconut and palm kernel oils, that may raise cholesterol. So, for the purposes of the traffic light model, I like to think of processed as nothing bad added, nothing good taken away. So in the above example, tomato juice could be thought of as relatively unprocessed, since even much of the fiber is retained, unless salt is added, which would make it a processed food in my book, and bump it out of the green zone. Similarly, I would consider chocolate processed, since they add sugar, but cocoa powder not. The limited role I see for yellow light foods in a healthy diet is to promote the consumption of green light foods. They can be the spoonful of sugar that makes the medicine go down. So if the only way I can get a patient to eat oatmeal in the morning is to make it creamy with almond milk, then tell them to add almond milk. The same could be said for red light foods. If the only way you're going to eat a big salad is to sprinkle it
with Bakos, sprinkle away. Bakos are what I refer to as ultra-processed foods, bearing no redeeming nutritional qualities or resemblance to anything that grew out of the ground, and often with added badness. Bakos, for example, have added trans fat, salt, sugar, and even red number 40, a food dye that may cause thousands of thyroid cancers every year. As a red light food, it should ideally be avoided. But if the alternative to your big spinach salad with Bakos is KFC, then it's better to sprinkle. The same goes for real bacon bits. I realize some people have religious or ethical objections to even trivial amounts of animal products. Growing up Jewish next to the largest pig factory west of the Mississippi, I can relate to both sentiments. But from a human health standpoint, when it comes to animal products and processed foods, it's the overall diet that matters. For example, without hot sauce, my intake of dark green leafy vegetables would plummet. Yeah, I could try making my own from scratch, but for the time being, the green ends justify the red means. On the same note, it's really the day-to-day stuff that matters most. It really shouldn't matter what we eat on special occasions. Feel free to put edible bacon-flavored candles on your birthday cake. I'm not actually making those up. Though I guess from a food safety point of view, a raw cake batter salmonella infection could leave you in dire straits. In general, it's really your regular routine that determines your long-term health. Our body has a remarkable ability to recover from sporadic insults as long as we're not habitually poking it with a fork. That's why, from a medical standpoint, I don't like the terms vegetarian and vegan, because they're only defined by what you don't eat. When I taught at Cornell, I had vegan students who appeared to be living off of French fries and beer. Vegan, perhaps, but not terribly health-promoting. That's why I prefer the term whole food, plant-based nutrition. In general, the dividing line between health-promoting and disease-promoting foods may be less plant versus animal-sourced foods, and more whole plant foods versus most everything else.